Tell that class average what?
Do you have to be married to a
Huh?
Do you have to be married to a
No. The guy, it's a guy
Okay.
over at Bud's Dental Clinic, and I hear about him every single time. And at every visit I used to go over there, there's a Dr. Ruggiero who's a dentist. One time he was my dentist, and we discussed the uniqueness of our last name. Yeah. Huh? Yeah, it's like just weird intersection. So, no, I'm not married to a dentist. Yeah. Huh? Being married to a dentist. Being married to a dentist. I know there's nothing wrong with being married to a man, I'm just saying, one of you has a cavity. Huh? Say that last part again? Cavity to the filling. Okay. Alright, we're not working blue today, you guys. Alright, does everybody know what that means, working blue? Stand-up comedy, dirty stand-up comics who use a lot of cuss words and like dirty jokes, stuff like that. The term for that is working blue, so we're not working blue today. Alright. Finish jokes, yeah. Alright, what the hell is going on right now? Alright, y'all. Oxygen measurements, let's do that instead. Alright? Yes. So, oxygen measurements we're going to talk about briefly today. We're going to talk about dissociation of hemoglobin. So, the basics of it, the very basics of it. And you guys said you haven't talked about the biochemistry of oxygen dissociation, like 2,3-DPG molecules, any of that stuff, right? That doesn't ring a bell at all. Okay. So it doesn't matter because we're not going to go into that depth whatsoever. We're just going to talk about the affinity of hemoglobin for oxygen in a given clinical circumstance or a given situation. Okay? So, understanding what I mean, affinity for hemoglobin is the affinity, like how much hemoglobin wants to grab onto that oxygen versus the dissociation, which is how much hemoglobin would want to get rid of the oxygen. Okay? And certain circumstances will push that chart one way or another, meaning that in acidity, hemoglobin wants to get rid of the oxygen. It wants to deliver oxygen to the tissues, right? Think about one reason for acidity could be something like lactic acidosis, which is just using your skeletal muscles, whether it's like rhabdo or other just lactic acid buildup because you're doing strenuous exercise, right? When you go into an alkaline pH, it wants to hold on to oxygen, right? It wants to hold on. And what is that? How is that relevant clinically? How much hemoglobin wants to hold on to oxygen? How is that? How do you think that's relevant clinically? Huh? Exactly, cellular respiration. If we have oxygen saturated on hemoglobin, that's all well and good. But if it can't deliver the oxygen to the tissues because it's holding onto it too tightly, then it is useless essentially, right? So that is it. In a given clinical circumstance, depending on the affinity of hemoglobin for oxygen, it may alter how you have to treat this patient because they may very well be saturating. You know, oxygen saturation, you guys know about pulse ox, right? Saturation of oxygen is great, it's 100%, but it's not delivering any of that oxygen to the tissues. So essentially, it's useless, right? Does that make sense? Okay. So I know this isn't on your slide. I know you guys have probably looked at hemoglobin in another class, but I wanted to just show it to you. It's a tetramer, 2 beta chains, 2 alpha chains. Each one of those chains has a heme group, and that heme group can hold on to an oxygen, meaning each hemoglobin molecule can hold on to 4 oxygen molecules, right? You guys seen this before, I hope, at some point? You guys haven't seen hemoglobin yet? Oh, well, this is hemoglobin. Okay? So a tetramer is a 4 unit of something. The two alpha chains and 2 beta chains. This is normal hemoglobin B, right? This is normal human hemoglobin. There are other kinds. Hemoglobin S, there's fetal hemoglobin, there's hemoglobin alpha, there's all kinds of different hemoglobins that are malformed depending on the patient's circumstance, right? So if you have a hemoglobin S, you have a hemoglobin that is prone to sickling the cell and deforming. That's how sickle cell anemia works. In this case, it's supposed to work like this. So you have 4 tetramers, 4 proteins, each one has a heme group, each one of those heme groups can grab an oxygen, okay? This is in a blood cell. So this is what's pulling the oxygen in and giving it to the tissues. So when I say hemoglobin dissociation, hemoglobin affinity, that's what I'm talking about, okay? Does that make sense? All right, I'm glad I added that slide then. So we'll talk about values that you will see and how they differentiate. We're not getting into arterial blood gas measurements. We're not really getting into this. I'm just telling you what they are. When you get to Clin Lab next semester, you'll dig deeper into this, and then as you get into pulmonology, you'll dig even deeper. At this point, we just need to understand what the values mean. Okay? So partial pressure of the oxygen. That's oxygen dissolved in blood. Remember, I don't know if you remember yesterday we talked about serum has a very low affinity for dissolving oxygen in, or which is to say that oxygen doesn't very freely dissolve into blood serum. So the lowest portion of oxygen that our body's carrying around is actually dissolved in our blood, physically, literally dissolved free in our blood floating around, all right? Partial pressure of oxygen, and then saturation of oxygen. That's a direct measurement, right? So the partial pressure measures how much oxygen is freely floating around in our blood. The saturation of oxygen measures directly how much is on the hemoglobin. Both of those are measured by arterial blood bags. Okay? Direct, taking blood from your artery and looking at it, running it through the machine. Okay? So those are direct measurements. They're clinically useful, especially when you get into acid-base measurements, acid-base problems. Okay? Somebody asked me yesterday about respiratory compensation for acidosis, meaning can you blow off enough carbon dioxide to fully compensate for an acidosis, right? Because that's when you guys learned that, I assume, right? Was that part of today's test? Right? So you remember Rome, right? Respiratory oxide metabolic equal. Hopefully he taught you that. That's an easy way to remember metabolic and respiratory acidoses. And so as one of your body's responses to an acidotic state is to blow off carbon dioxide, to get rid of carbon dioxide, hyperventilation. And yes, you can compensate to a point, but you cannot compensate through to a normal pH. And even if you can, it doesn't absolve the underlying metabolic acidosis, right? Meaning, think about a state like diabetes. You guys ever heard of diabetic ketoacidosis? It is a metabolic acidosis, meaning it's not a lung or respiratory problem. It is a metabolic problem, a kidney problem. It's not being able to clear all of the keto acids that are forming because you can't use your glucose, right? So you go into anaerobic respiration, you start to build up ketones, okay? You also start to build up lactate with anaerobic respiration. So your body, responding to all of that extra hydrogen, is starting to blow off carbonic acid as much as you can. So even if you compensate back up from the metabolic acidosis into a normal pH range, you're still not solving the problem, okay? So does that make sense? I know it wasn't anything that you asked, but does that make sense to you guys? I used, obviously in nephrology, I used to teach a lot deeper into acid-base disorders, and you'll get that in pulmonology too, but clinically speaking, just as you move forward in your training, understand that if for an acid-based problem, it's not an acid-based solution. So if we have a metabolic acidosis, we're not just going to pump bicarbonate to this person. We're going to figure out what's causing their metabolic acidosis, or else it's never going to go away. So acidosis or alkalosis is a symptom of a problem, and we have to figure out the problem, not treat the symptom. Does that make sense? Because you can administer hydrochloric acid to patients if they're in severe alkalosis. Did you know that? So, I mean, you can, but then you're just treating the symptom, right? It's like putting a Band-Aid on a bleeder. It's not going to work. You know what I mean? Does that make sense? And it's relevant here because it does. We will talk about acid-base relationships a little bit when it comes to alkalinity and oxygen dissociation. Pulse ox, everybody in here is probably familiar with pulse ox, right? The little machine you put on your finger. Calorimetric, right? Calorimetric measurements. What does that mean? It reads color. So that means it can be thrown off in a certain clinical circumstance. Like, for example, if you have carbon monoxide poisoning, you will have a very good looking SpO2 because the carboxyhemoglobin is still red, but you will have almost no oxygen carrying capacity because the heme is being occupied by carbon monoxide instead of oxygen, right? Another clinical circumstance where SpO2 can be easily thrown off is anemia. And what is anemia? Not enough red blood cells. Very simply put, anemia is I don't have enough erythrocytes, right? So all the erythrocytes that you have may be saturated with oxygen. So you may have a really great looking SpO2, but you don't have enough red cell capacity because you don't have enough red cells. So your actual oxygen delivery to the tissues is going to look like crap. So Point is, given clinical circumstance, you have to understand why one or more of these values might be thrown off. But for this point, does everybody just understand what they are? Okay? Alright. And then if you don't understand what I mean by calorimetric measurements, essentially that's what it is. The pulse ox has an infrared light that just reads through the actual finger and just picks up the color and calculates that into a percentage of oxygen saturation of hemoglobin, peripherally, right? Okay? And again, we talked about carbon monoxide. So carbon monoxide has a much higher affinity. So if you have somebody who has smoke inhalation or some other carbon monoxide related injury, if they're just in a house that has a carbon monoxide buildup, carboxyhemoglobin, which is what happens when you bind carbon monoxide to hemoglobin, has a much higher affinity to stick together, and it's hard to break it off, right? So if the oxygen is knocked off hemoglobin, right, like it says, then where does it go? It just doesn't disappear. It goes into the serum even though it has a low solubility. So our PaO2 will actually go up in carbon monoxide. So it'll look like we have a pretty decent partial pressure of oxygen dissolved in the serum, right? Same thing with the calorimetric measurements. Like I said, it still looks red. So our pulse ox might look great, even though this patient is turning blue because they are not oxygenated. Does that make sense? So they're carrying around a whole bunch of carboxyhemoglobin that looks great and bright red for the pulse ox. There's more oxygen dissolved in their blood because it's getting knocked off the hemoglobin. So their PaO2 might be okay or even increase, but this patient isn't oxygenating their tissues. They'll still have cyanosis and signs of respiratory distress. Does that make sense? Okay. So yeah, this is essentially what we just said. And this is another good application of Henry's law there. So if we increase the atmospheric pressure of oxygen, like if we put them in a hyperbaric chamber and force that carboxyhemoglobin off the molecule and force the oxygen on, then we can help treat carbon monoxide poisoning that way. All right? So, could work. Sometimes you just need high percent O2 and it'll work as well, depending on how bad the patient is. Okay? Any questions? Okay. So as I said, oxygen not very soluble. Most of our oxygen is floating around on those hemoglobin molecules. Okay? The vast majority. Okay? So that is why oxygen dissociation is so important. That's why it becomes really, really clinically relevant to understand the situation that your patient is in and understand sort of the physics and the biochemistry behind it at a foundational level here. Because if you don't understand how the oxygen is actually getting to the tissues, because like I said, that's fantastic. 98.5% of oxygen, whatever the actual percentage is on hemoglobin, and that's great. But we have to get it to the end line, right? We have to get it to the internal respiratory state, right? Putting oxygen on hemoglobin is fantastic. Delivering oxygen to the tissues is the point of the whole exercise, right? All right. So, as we said, Henry's law, again, the partial pressure of a gas is relative to the amount of that gas dissolved in a liquid. So, higher partial pressure, higher pressure of oxygen equals more dissolved in our blood and more bound to hemoglobin as a matter of fact as well, okay? So, the important thing here is, and I don't know if I mentioned it, we talked about yesterday, we brought up the very small diffusion distance that blood has to go in order to unload that oxygen, right, in the lungs. Most of that is happening obviously in the capillary bed, right, in the capillaries of the alveoli, because that's where it's happening. They kind of boxcar through and pick up oxygen and move their way through. Most of the hemoglobin, most of those 4 spots for oxygen are already saturated before they get to the end of the capillary bed. So before it's ready to go out into the systemic circulation, if you will. So that efficiency also helps fully oxygenate those hemoglobin molecules, even in states where the blood's moving faster, like if you're exercising or something like that. Does that make sense to everybody? So the diffusion distance is small, but the oxygenation is very efficient as it occurs almost before it actually leaves the capillary bed. So it's putting on oxygen early and often and moving out to the tissues. Does that kind of make sense? No? I'm not getting any head movement whatsoever here. Okay?
Can you repeat it one more time, sir?
Sure I can. The oxygen is getting put on in the capillary bed, right? The oxygen is being put on those hemoglobin molecules, those heme groups in the capillary bed. But the capillary bed is a system of capillaries, right? The saturation of that hemoglobin molecule with all four of those oxygen molecules happens early on in the capillary bed. So it's early in the process, which means that think about production line speeding up. Have you ever seen I Love Lucy? When the production line speeds up and she starts eating the chunk. But even as production line speeds up, it's still getting oxygenated fully, right? So you don't want basically your hemoglobin leaving with 2 or 3 or 1 oxygen molecule. So the fact that it happens early on in the process means that if the production line speeds up, we still are able to effectively put all 4 molecules of oxygen on there. Does that make sense? Okay. And then what this is exactly what we've been talking about with partial pressures, right? We have a high pressure of oxygen in the capillary blood and now on the erythrocyte, right? We have a low pressure of oxygen at the tissues, which means we exchange oxygen for carbon dioxide effectively through simple diffusion, right? Okay. So, this can be a bear, but it's not. Okay, we're going to take it down. Now. All right. Oxygen hemoglobin dissociation curve. Okay? It's a graphical representation for the partial pressure of oxygen and the percent of saturation. And it has a normal range. If it shifts to the right or if it shifts to the left, it means that oxygen either doesn't dissociate as easily or it dissociates more easily. Okay? So, as we get more atmospheric, like higher pressures of oxygen, right? Again, think about Henry's law, think about a hyperbaric chamber. As the pressure, the external pressure of oxygen in the air increases, the affinity for hemoglobin to grab onto it increases as well, which is why it helps bump carboxyhemoglobin off in the treatment of carbon monoxide poisoning. Okay? As the saturation of oxygen in the surrounding air goes down, and where do you think this happens? Like where would you be where there's less oxygen in the air? Huh? You guys remember Price is Right? Little guy who goes up. Anybody ever watch Price is Right?
Oh, yes.
Oh, what do you read? Yeah, that guy. Right. Price is Right was awesome. It meant you were home sick for school. But the crappy thing about Price is Right is after it was over, it was soap opera time. You had to go to sleep and do something else. Anyway, so if you don't know what I'm talking about, a little yodel guy. As you go up to altitude, you get less oxygen. There's less oxygen at altitude. All right? So your affinity for hemoglobin goes down, so you start to offload it. All right? So that's one of the circumstances that you should be aware of. Right? You want more delivery of oxygen to the tissues when there's less oxygen in the air to take in, so you have a relative hypoxia. Okay? So, anyway, that's just one. But does that make sense? How this kind of applies clinically. So this is our normal oxygen dissociation curve, and as you're here on this side of it, so oxygenated blood in systemic artery, so think closer to your heart, right? You're 100% saturated, all right? Close to 100% saturated, at about 100% PO2. That's where we're going to say alveolar air is 100% O2. That's what's getting dropped out from the blood, so we're almost 100% saturated, fully saturated. As we move away, right, we're in veins now. Where is it? As we're in veins, there's less oxygen pressure, and there's less oxygen bound to hemoglobin, and all the way down here at sort of the tissue level, right, contracting skeletal muscle, so muscle that is using the oxygen, there's a lot less oxygen and a lot lower affinity for that oxygen. And what does that mean? That means it's good. When we get down to a lower saturation level, we're giving the oxygen to the tissues and we're picking up carbon dioxide. So this is our normal oxygen dissociation curve. And don't worry about the numbers, don't worry about the line, understand the concept. Does it make sense? You guys, does it make kind of make sense? Let me put in a couple of different clinical pictures and see if it makes better sense, all right? So things affect the affinity. It's going to pop off more, or it's going to stay on. Okay. These are our main ones. The other ones that should be on here, or could be on here again, is altitude, but we're not going to discuss altitude. We're just going to use these as decent examples at this level. Okay. So acidity. When you are acidotic, what does that mean? Means you have too much hydrogen running around, not enough bicarb, right? It's a hydrogen problem, whether you have respiratory acidosis, metabolic acidosis, whatever it is, okay? So, again, the easiest example, I think, is lactic acidosis, right? Means your muscles are using anaerobic respiration, you're creating and building up lactic acid. Everybody knows what lactic acid is. All of you here gone for a run before. Your tissues need more oxygen delivery, and so a lower pH is going to offload oxygen easier because we're in a state where we need to get the oxygen off the hemoglobin and into the tissue. Does that make sense? I'll show you the graph in just a second. Alkalinity, opposite, just the opposite, okay? Respiratory alkalosis, metabolic alkalosis. Metabolic alkalosis is usually an iatrogenic problem, meaning that the provider causes it on accident. Respiratory alkalosis, hyperventilation for some reason, okay? So, this is the pH curve. Our black line here represents normal, right, homeostasis. This is acidosis, and this is alkalosis, okay? So, again, just as an example, you're looking here at the same oxygen saturation here. You have less here and more here, right? So you're shifting over, right? So the line shifts up here, the line shifts down here. This is where we are for about, so at a given 30, right? Oxygen is about 39% saturated on hemoglobin, about 59% at normal, and all the way up to about 65 in alkalosis, right? So acidosis pushes it off more, alkalosis makes it harder to come off. Does that make sense? Those numbers, again, just random example numbers, but does the curve shifting one way or another make sense to you in acidosis or alkalosis? Kind of? Anybody else? Anybody not? Okay. How do you think it's going to look for increase, decrease in CO2, given what you just learned about respiratory acidosis? It's going to look essentially the same. The shift of the curve for PCO2 increase is going to look almost essentially the same as the acidosis alkalosis curve. And why? Because increase in PCO2 or decrease in PCO2 can precipitate alkalosis, acidosis. Respiratory, right? Does that make sense? And it really does look essentially like that. And then as temperature increases, hemoglobin affinity decreases. And why is that? Physiologically useful. What do you think about it? What happens to your body temperature if you have to run away from the tiger? It goes up, right? So increase in temperature means that we're going to increase delivery of oxygen molecules to those tissues, so we have oxygen not in our hemoglobin, but in the tissues where we need it. Does that make sense? Okay? Now clinically that can create a whole host of problems if you have somebody who's febrile, so on and so forth, or somebody who's hypothermic, Hypothermia will keep that oxygen on the hemoglobin, so that's bad, right? So you have to understand how that's going to happen when you're treating this patient. For now, how we're going to do that is not important. Just understand, temperature increase throws oxygen off hemoglobin, temperature decrease keeps it on. Does that make sense? Okay? And so you ask, what about that? Somebody's probably going to ask, what about therapeutic hypothermia after cardiac arrest, something like that? It does protect your neurological tissues, but it does decrease oxygen delivery to the peripheral tissue. So there's a balance. But in general, our brain is more important than our feet. So we like to keep that, together if we can. So looking at this is a PCO2 curve. Like I said, you'll notice it's almost exactly like the acidosis alkalosis example, right? Because again, it's very, very closely related. Temperature, right? So 110 degrees of very severe fever. We're dropping oxygen off a lot. We go down to 68, of course, very almost non-survivable hypothermia, and the oxygen is staying on, right? So we're not delivering any of that oxygen to the tissue. Does that make sense? Okay. And then this puts it all together on one if you want to take a look at it, depending on how that explanation in the slides goes for you. This just puts it all together. I know that you guys haven't done the biochemistry of this yet, so when you don't worry about what DPG means. Diphosphogluconate, it's just another molecule that affects the oxygen affinity. Don't worry about it. So if you see that, don't ask me because I don't want you to know, okay? Any questions about that, the oxygen dissociation stuff? Okay. It gets easier from here. So that was the difficult part, but like I said, try to make it as not difficult as possible. The takeaway from this slide, honestly, is here. Most of our dissolved carbon dioxide is actually floating around in the form of bicarb. All right, and then when bicarb dissociates down to CO2 and H2O, what do we do with it? Breathe it out. Okay? Okay. Now we're going to neural control the respiration, get into some easy stuff, and then we're going to be done and go look at some lungs. Okay? So simple, right? This is the basically utilization of oxygen and respiration as you go from a resting state to a exercise state or excited state, and then that bottom one is essentially as you increase your aerobic capacity or VO2 max. Anybody familiar with that term? Volume of oxygen using, so VO2 max. Then you can utilize even more oxygen and bring it in even farther, okay? Respiratory center in the brain, you guys remember we talked about, set areas in the brain that control certain things. Now this is the control for respiration. Collectively, it's called the respiratory center. Nice enough, okay? And you look at, we're going to define all of these. The pons, the medulla, and the spinal cord. So we have these areas here, and the pons in these areas, and the medullary rhythmicity center, right? Easy. That's where it is, at least. So, the medullary rhythmicity center, it controls rhythm. So that's good, the basic rhythm of inspiration, right? So kids who threaten to hold their breath until they die, they, even if they are able to pass out, they'll still keep breathing after they pass out, which is, Pneumotaxic center, coordination between inhalation and exhalation. What it really does is it has baroreceptors that ensure that we don't blow up our lungs with overinflation, okay? So it just transitions our inspiration to expiration in general. The basic rhythm, again, the medullary rhythmicity center. This here in the pons, the pneumotaxic center, helps us transition from breathing in to breathing out. So we can't overinflate. There's a point where we can stop. Apneustic center coordinates between inhalation. This one, what does this sound like to you? Huh? Yawning? Sounds like yawning to me. Right? So if you get a little bit hypoxic, and you start to, that's really why you yawn. And then when one person yawns, everybody starts to yawn because it's viral, right? But again, it's overridden. This is overridden. The deep inhalation that would happen with the apneustic center is overridden still by the pneumotaxic center, meaning you still can't overinflate your lungs, okay? No need to oversimplify, or no need to overcomplicate, excuse me, a fairly simple concept. So, as you know, you can control your own breathing. You can take a deep breath in, you can take a deep breath, you can blow more air out, you can breathe faster if you want, right? Cortical influence, what does that mean? The cerebral cortex, higher brain function. You can override this stuff to a certain point, okay? Voluntary control does help us hold our breath, right? And stop breathing in gas chambers and things like that, you know, if you're in the doing stupid stuff like that, right? But the chemotaxic centers that recognize increases in CO2, increases in hydrogen, so acidity, override any cortical control. So ultimately, breathing is involuntary, although we can create and exert some influence over it. You guys know that already. Okay. Our central chemoreceptors in the medulla, they look at basically the acidity. All right. Increases in hydrogen and carbonic acid, carbon dioxide, and peripheral chemoreceptors also take into account saturation of oxygen. Okay, so they recognize low O2 or hypoxia. And the proprioceptors, basically the easiest way to think about this is you're breathing at rest right now. When you stand up and start walking, proprioceptors will engage and say, our leg tissue needs more oxygen, we need to breathe a little bit faster to deliver some oxygen because our muscles are working now. That's essentially what the proprioceptors do. Does that make sense? Okay. Other minor, more minor influence, limbic system. So when you get emotional, when you get sad, when you get happy, you can breathe, you know, if you're excited, you start to hyperventilate. Okay. Temperature, when you do have a fever, you breathe faster. Tachypnea usually goes along with fever, all right? Also, this one, the mammalian reflex. Have you ever heard of that? You know, so you jump into cold water and you cease breathing really fast, or you stick your face in cold water, okay? Pain, obviously. If somebody's in pain, if you have somebody who comes to you and they're on the legit 6, 7, 8 out of 10 pain, typically that'll manifest as also tachycardia and tachypnea. They'll be breathing a little bit faster. Maybe not true tachypnea, but at least an increase in breathing rate because pain does incite people to breathe faster. Okay. Irritation of the airways, sneeze and cough reflex, that's easy enough. Blood pressure can change just based on the baroreceptors that we have in carotid arches and carotid bodies, right? We talked about a while ago. And then stretching of the anal sphincter muscle. Did I say anal? Okay, good. That's awesome. Write that down. Anal sphincter muscle can stimulate breathing. Sometimes you use it on infants, sometimes you use it on patients who are passed out. See if you can get them to breathe. Right? Huh? Yeah. Yes. You got to check for anal wink and make sure that they're okay. And then aging in the respiratory system. This is the last one. We lose elasticity everywhere, including the lung tissue. We lose our kidneys in a state of chronic kidney disease, create less erythropoietin, which means we're sort of in a chronic anemia or chronic disease, whether we like it or not, depending on how sick we actually are. So we have less oxygen carrying capacity to begin with. We have fewer macrophages, right? Those the little dust cells, right, that are the dust busters of the lungs. And this is also a big one, decrease in ciliary action. So what does that mean? It means we're not clearing as much crap out of the lungs just based on the lack of macrophage activity, and we're not washing stuff, that foreign objects and foreign matter out with the ciliary activity. We have less of that. So more secretions, more stuff gets in. Older folks are more likely and more susceptible to pulmonary disease because of a couple of those reasons. Right? That's it for today. Kept it to about a half an hour, so you can take a little break and transition to lab. But the first group can come on over. I've already got it set up. Let me just get over there, and you guys come on over when you're ready. Any questions? Any questions about that stuff? Hopefully that didn't seem rushed. The oxygen association stuff and the pulse ox, the oxygen readings and lab values. We just need a very basic understanding in here. So if you have any questions about it, if anything from yesterday or today seems unclear, we have all the way until next Friday before the exam. So you have plenty of time to formulate any questions as you interrogate this material further. hope it didn't seem rushed, I wasn't trying to. So, yeah, I won't take up any more of our time in here. Let's get to looking at some lungs. Just so you know, just be careful with Adam. I'm gonna open up Adam so we can see him. Just be careful with him. I found out he being here has been here for 40 years, which means Adam died and that 40 years is probably that's probably been 40 years for the past 10 years. So Adam probably died in the 70s, which explains the mustache probably. Nothing explains your mustache, but that explains Adam's. And so, just be careful. Every the specimens, they're pretty squishy. Okay, so I'll be in there. There are specimens lined up for Dr. Sutliff's class.